going to talk about ectopic pregnancy, which is a topic that interests most emergency physicians and is a concern for people working in primary care. Hopefully we can go through the basics and as well as talk and explore about some of the management decisions down the line. So first of all, ectopic pregnancies occur in about 1 to 2% of pregnancies, and that incidence is rising, and that's thought to be due to a couple of things like advancing maternal age and increased use of assisted reproductive technology. The vast majority of these pregnancies that are ectopic are in the fallopian tube, and I've got a picture just in a second. And the vast minority are in other places such as the ovary or the cervix or a caesarean scar or remotely in the abdomen. And hopefully this picture reflects that. Ectopic pregnancies initially increased in vitro fertilisation, although the rate of ectopic is becoming similar to spontaneous pregnancy. It's worth mentioning that heterotropic pregnancy is an entity that exists, and that is where you have an intrauterine pregnancy and an ectopic pregnancy, but it's quite rare, probably only 1 in 4,000 women, and although this number is smaller, as in it's more common in assisted fertility. This is a laparoscopic picture of a right tubal pregnancy at the bottom right hand side of the photograph with associated hemoperitoneum. So this is a ruptured ectopic pregnancy, and this is the complication that we fear most due to its ability to, kill young women. Now, there's many risk factors for ectopic pregnancy, and they've been studied in a bit more detail, and I just wanted to present mainly the risk factors associated with a stronger odds ratio. And so those factors with an odds ratio greater than 4 include prior tubal surgery, prior ectopic pregnancy, sterilisation, and use of intrauterine contraceptive device. Now, this is worth talking about. The rate of ectopic pregnancy in women with an intrauterine contraceptive device is no higher than the background population, although in the women who do get pregnant with an intrauterine device, about half of those are ectopic when you consider the levonorgestrel device. It's a bit lower than that with the copper IUD. There's some other risk factors here that have a weaker association with ectopic pregnancy that I'll just put up for your reference. Now, in terms of patient assessment, it generally follows a fairly similar process. Taking a history, both general and obstetric history, with an exploration of whatever symptoms the woman's come in with, and going about a process of forming a risk assessment for ectopic pregnancy. The clinical exam, depends on how well or unwell the woman is, but the key points are the hemodynamic status, the presence of abdominal findings or peritonism. Now, the role of a vaginal or speculum exam is a bit controversial. You'll find that doctors working in a primarily obstetric practice will err towards doing a examination on every woman. Doctors working more in a emergency department or primary care clinic will do less of these examinations, and I think probably the right answer is somewhere in the middle, and I think it really should change your management of the patient, and I'm not sure that it does in all cases, but I think there's certainly some where it does, and we might elaborate on that a little bit more later. I think the role of point-of-care ultrasound is probably reducing the need for these examinations up front. And then, as always in early pregnancy, the questions that you ask are, 1, is there free fluid? If there is free fluid, that's highly suggestive that you have a ruptured ectopic pregnancy, although finding free fluid in all pregnant women is going to be rare. Is an intrauterine pregnancy present? Now, if an intrauterine pregnancy is present in a woman who is not on assisted reproduction, then the likelihood of ectopic pregnancy is extremely low. So we often use the presence of an ectopic pregnancy to exclude... we use the presence of an intrauterine pregnancy to exclude an ectopic pregnancy. The last one, if you do see a pregnancy, is it viable? And this is most relevant to those that are intrauterine. In terms of tests we do fairly standard blood panel of hemoglobin group and hold, and beta HCG level. The beta HCG level is useful in confirming pregnancy. It can be useful in getting a level which might help us predict what we may see on a pelvic ultrasound, but it's important to remember that in the setting of an ectopic pregnancy, beta HCG is secreted very irregularly, and what I mean by that, or maybe inconsistently is a better word, whereby there's been case reports of ectopic pregnancies rupturing with a beta HCG level of 5, and then there's been ectopic pregnancies where the levels have been in the hundreds of thousands. So the beta HCG production is not as reliable. The hallmark to diagnosis the pelvic ultrasound. Now the caveat here is that you have a stable patient. A woman with a suspicion of ectopic pregnancy and free fluid on bedside ultrasound is an ectopic pregnancy until proven otherwise at laparoscopy, and if the patient is unstable, the ultrasound department is the last place that they should be taken. We might talk a little bit about the ultrasound findings in general. This is a longitudinal section of a uterus on transvaginal scan. You can see the uterine wall there, and there's a thick endometrium, although no gestational sac. Most ectopic pregnancies are identifiable by the fact that there is no intrauterine pregnancy and that there is an adnexal mass. If within that adnexal mass or extrauterine mass there is a yolk sac, then as with an intrauterine pregnancy, that confirms that that is a pregnancy and therefore diagnoses an ectopic pregnancy. And of course, if you see a fetal pole, that's, is equally suggestive. Now, things that might suggest to you sonographically that there's been a ruptured ectopic pregnancy include free fluid in the pouch of Douglas. There's a very, very trace amount on that image on the right. Free fluid in Morrison's pouch, which is the hepatorenal recess in the right upper quadrant. This really suggests there's been a significant amount of hemoperitoneum, generally upwards of several hundred mils, and that increases the urgency of the operating theatre. And I think that helps make decisions as to the urgency of their laparoscopic salpingectomy. Some other examples of ultrasound findings. Here we have a transverse section of the uterus with a adnexal mass as demonstrated by that arrow. You can probably make out there might be a fetal pole in there, but it's not clear on that image. And on the right here we have a similar adnexal mass with colour Doppler placed on there, and this shows the ring of fire sign, which is essentially peripheral vascularity around the adnexal mass, but unfortunately that doesn't distinguish between a corpus luteum and an ectopic pregnancy. And I've personally seen a case where a corpus luteum has ruptured and caused a 4-litre hemoperitoneum with an associated intrauterine pregnancy. But of course that's going to be an absolute red herring diagnosis in the setting of hemodynamic instability and large hemoperitoneum, but more just to understand that other conditions exist. Just show you some examples of intra-abdominal free fluid. This is the lower aspect of the uterus, and therefore blood in the pouch of Douglas. And on the right here, this is some free fluid, which I'll just demonstrate, is this hypoechoic area in between the liver and the kidney. And this is commonly used as part of a FAST scan, as the emergency listeners would be aware. In terms of management of ectopic pregnancy, it really depends on whether the patient is stable or unstable. And in the unstable group, it's relatively straightforward. The job really is to resuscitate with early blood products and or massive transfusion protocol. Start supportive care such as analgesia if the woman has significant pain, and probably the most hemodynamically stable option would be intravenous fentanyl. And then the specific care, getting on the phone and organising the operating theatre. Now I put here for salpingectomy, it's quite uncommon to do tube preservation surgery in the setting of a ruptured ectopic, but we'll discuss the other surgical options when we talk about the stable patient. And this is another laparoscopic picture of a ruptured tubal pregnancy. Now when we talk about the management of a stable patient with an ectopic pregnancy, there really are several options. conservative management, medical management, and surgical management. Now, in all places I've worked, surgical management has predominated, and I think that's because it's arguably it is probably the safest from the point of view that the pregnancy has been definitively managed. Obviously, it has its associated anaesthetic and surgical risks, as well as loss of a fallopian tube and therefore its impact on fertility, but that's certainly been the practice in most places I've worked. But if we talk about them all briefly, conservative management can be appropriate. This is a decision that should be made at a senior level with very close follow-up and return precautions to the woman in a well-selected low-risk patient. And this is most commonly in an ectopic pregnancy with a falling beta-HCG level. In terms of medical management, it's most commonly done with methotrexate given intramuscularly. Again, women need to be well selected and they need to be closely followed up with return and have return precautions to the emergency department with this form of management. Now, the ideal indications for a woman to receive medical management include having no abnormality of vital signs and no pain, having reliable follow-up and not being isolated from returning to the hospital, having a small adnexal mass, so less than 3 centimetres in size with no fetal cardiac activity, a beta-HCG less than 5,000, and then you need to have a medical, at least a consideration of comorbidities prior to having methotrexate due to its inherent adverse effects. Now, in terms of the size and beta-HCG level indications, these aren't black and white, but smaller gestations and lower beta-HCG levels have been associated with lower failure rates of methotrexate, which is the reason that they're part of these indications. In terms of surgical management, really the main forms are to do a salpingectomy, which involves removing either just the affected part of the tube or, if distally, the distal end of the tube, versus a salpingostomy, which involves making an incision in the tube and removing the pregnancy from that area and leaving the tube as is. I won't go into the details of choosing one over the other, but in summary, an unstable patient will almost certainly get a salpingectomy, and in a stable patient, it's often a decision as to the health of the contralateral tube and therefore a assessment of the likely impact of a salpingectomy on that woman's future fertility. Now, laparoscopy versus laparotomy. Interestingly, really, even in unstable patients, a laparoscopy is the standard of care, and it generally is so because it is a very rapid entry into the abdomen, and the bleeding itself from the fallopian tube is not as, I guess, brisk as other forms of obstetric hemorrhage. It's often the case that the hemodynamic instability occurs after a relatively well young woman has been able to compensate physiologically for quite a while. A laparotomy is done in some cases. It might be done in a rural centre where laparoscopic skills aren't present, or in a woman with significant adhesions for preventing easy access to the pelvis, or at surgeon preference, but increasingly it's being acknowledged that even in the unstable patient, a laparoscopic approach is very appropriate. Now, the indications for surgical management include rupture or instability, which we've discussed, if there's ongoing significant bleeding, or if the patient's not suitable for medical or expectant management. And also remembering that the patient's part of this decision-making process, and quite a lot of them are happy to just have the pregnancy managed, and therefore will just go for surgical management, irrespective of their candidacy for the other options. So I hope that's clarified some of the basics around ectopic pregnancy. I hope it's given you a little bit more knowledge about some of the definitive therapies and give everyone a better idea of what this patient's progression through the healthcare system might include. So that's all I have to say. Thanks very much for listening. And if you're prepping for exams and want more free practice, jump onto freeobstetricexam.com. And if you'd like a deeper, structured approach to learning obstetrics, the kind that actually sticks, check out theobstetriccourse.com anytime.